Recording in progress. Good day, ladies and gentlemen. Selamat pagi, selamat siang, selamat malam to everyone who's watching around the world. We extend a warm welcome to the distinguished speakers, guests, researchers, policy influencers, and relevant stakeholders around the world. My name is Rizky Ramadan, and I am going to serve as the Master of Ceremony for today's webinar. And welcome to the second day of the T20 webinar, Putting People at the Center of the Health System. Before we are going to continue the event, we would like to deliver our warmest welcome to the honorable guests. Joining us tonight is the head of the Financial Sector Policy Center, Financial Sector Policy, the Ministry of Finance, the Republic of Indonesia, Mr. Adi Budiarso. Good evening, sir.
Good evening,
And also
Mas
joining us
Rizky.
tonight is the T20 Executive Co-Chair, the Institute for Economic and Social Research, Faculty of Economics and Business, Universitas Indonesia. Please welcome Ms. Riatu Mariatul Kiptia. Good evening, ma'am. And also joining us tonight is the chairman of the Indonesian Health Economist Association, Mr. Hasbullah Tabrani. Good evening, sir. So, ladies and gentlemen, for your information, this webinar is held by the co-hosts of the Task Force 6 T20 Indonesia co-hosts. They are the U.S. Agency for the International Development, or USAID, and the Indonesian Health Economist Association, or InaHEA, or in Indonesian is Ikatan Ekonom Kesehatan Indonesia, or IEKI, which is a scientific organization of health economists and a convening organization for health economics experts in Indonesia. This 2 days event focuses on the third policy areas listed under Task Force 6, namely investment and reform of health systems to guarantee their resilience to achieve universal health coverage. This event aims to gather and synthesize the ideas related to build advanced and sustainable health financing to achieve resilient public health care in low and middle income countries. Ladies and gentlemen, before we are going to start the event, let me explain about the housekeeping rules that must be obeyed throughout the event. They are, first, today's webinar is being recorded as well as being live streamed at the official YouTube channel of the Faculty of Public Health, Universitas Indonesia. Secondly, we provide translation services, so if you feel the need to use the service, please kindly check on the globe icon below. And also, we are going to have a question and answer session by the end of every discussion. So if you want to ask anything, please drop your question using the Q&A function. And lastly, we are going to share the link of attendance and the link of evaluation form on the chat box. So please fill out the attendance list and the evaluation form so that we can conduct our next event better. Ladies and gentlemen, before we start our event, let's hear the welcoming remark which will be delivered by the head of Financial Sector Policy Center, Financial Sector Policy, the Ministry of Finance, the Republic of Indonesia. Please welcome Mr. Adi Budiarso.
Thank you so much, Mas Rizky. Distinguished guests, ladies and gentlemen, from especially Ministry of Health, distinguished guests, ladies and gentlemen, especially from leadership of BPJS, distinguished guests, ladies and gentlemen from Indonesian Health Economic Association, allow me to convey that Mr. Fabrio currently would not be able to deliver the opening remarks. So I, on behalf of him, I would like to convey that this important meetings or T20 webinar is really in line with the intention of the government to support Indonesia National Health Insurance Program, achievement and outlook, especially how to put the people at the center. First of all, I would like to convey my sincere appreciation to the Indonesian Health Economic Association for organizing this important event about putting people at the center of the health system, advancing health financing, strengthening primary care, engaging public and private sectors that discuss contemporary issue in Indonesia health system. It is great honor for me to be here today with all of you. For more than a decade, Indonesia already has a national social security system, SJSN, that aims to provide health protection and improve welfare for all Indonesians. SJSN is expected to provide basic needs guarantees for each participants and their household members. Through this program, it is hoped that the community basic needs, if they face life-changing events that can affect their income, such as accident, unemployment, or retirement age. In implementing the national social security system, the government established the Social Security Administering Body, or so-called BPJS, through the law number 24, 2011, to administer employment social security and health social security programs. The Employment Social Security Program is organized by BPJS Ketenagakerjaan, or BP Jam Sostek, which manage various programs such as old age security, JHT, pension security, GP, work programs such as old age security, GP, work accident insurance, JKK, death security, JKM, and job loss insurance, or JKP. On the other hand, the National Health Insurance, or JKN, is managed by the BPJS Kesehatan. This program can be classified into two main principles, insurance and pension funds. The JHT and GP programs are run on the principle of the pension fund, in which the program's benefits will be paid when retirement and disbursement criteria are reached as stipulated in the regulation. Meanwhile, the JKK, JKM, JKP, and JKN programs are run on the principle of insurance funds, that the program benefits will cover participants' risk when certain condition event occurs. Ladies and gentlemen, the National Health Insurance Program is a government program that aims to provide comprehensive health insurance for every citizen of Indonesia, so that the Indonesia population can live a healthy, productive, and prosperous life. The benefits of this program are provided in the form of comprehensive individual health system services, including health improvement services to be promotive, disease prevention to be preventive, treatment to be curative, and recovery to be rehabilitative, including drugs and medical materials by using quality of services and cost effectiveness, or to manage with care. The JKN program is organized based on the principle of social insurance and equity in obtaining services according to medical needs that are not related to the number of contributions that have been paid. This principle is realized by paying contribution at a certain percentage of wages for those who have income, and government paying contribution for the poor. JKN membership coverage continues to increase in 2014. As many as 133.4 million people became JKN participants, which cover more than 52% of Indonesian population. In 2021, the number of JKN participants increased to more than 235 people, or more than 86% of population. This condition shows a positive trend in achieving the participation target, which is 98% in 2024. This is according to 2020-2024 RPJMN, or long-term planning at the national level. Indonesia is also showing a positive progress in achieving universal health coverage, or UHC. The National Security Council, the GSN, has drawn up a roadmap for implementing the social security system. Based on the 2012 to 2019 National Health Insurance Roadmap, one of the expected achievements is the fulfillment of universal health coverage. In 2018, the Universal Health Coverage Index for Indonesia was 60, according to Prakarsa 2018, in the Universal Health Coverage Measuring Indonesia Achievement Report. The index value is higher than the measurement made by WHO through Tracking Universal Health Coverage in 2017 Global Monitoring Report, which was scored Indonesia at 46 in 2015. The Universal Health Coverage Service Coverage Index presents a numerical value based on a scale of 1 to 100, where the higher index is the better result. This value represents the achievement made to be public health needs in promotive, preventive, curative, rehabilitation, and palliative activities, as well as the quality services to improve health. JKN reform is carried out by improving the quality of services and cost effectiveness of JKN, adjusting JKN fees and validity of JKN PBI or cost supported by government data, as well as strengthening the role of local government in implementing JKN program. To continue improving national health insurance system, the government applies the standard inpatient class, we call it CRIS, to enhance the quality of health services and apply the equity principles. Distinguished guys, ladies and gentlemen, the COVID-19 pandemic was unprecedented and really extraordinary shock that significantly impacted health, society, and the economy. Addressing this pandemic impact, the government took extraordinary policy through National Economic Recovery Program, we call it PEN, which substantially emphasizes on the health sector. The economic recovery has to start with better COVID-19 measures. COVID-19 pandemic reminds us again that the strategic value of health for our economy and healthier people lead to a more productive nation. Aside from its negative impact, the pandemic has also provided momentum for the government to accelerate structural reforms, including in health sector. The government commitment to health development has been manifested through 5% of state budget allocated for health since 2016. This year, we allocated more than 8% of state budget for health directed for COVID-19 measures, such as vaccination and medical treatment, and strengthening the national health reform, including accelerating stunting reduction program. Transitioning from pandemic to endemic, government should maintain the improvement of health preparedness, including providing healthcare facilities and strengthening the testing and tracing systems. In closing, ladies and gentlemen, I would like to emphasize that Indonesia already has a national social security system that aims to provide protection and improve welfare for Indonesian people. Improving the national security system is not the exclusive task of the government, the parliament, and the relevant authorities. The government is really open to constructive inputs from international partners, research institutions, experts, and especially the general public. With combined efforts, hopefully, the national Indonesian social security system will become much more developed and stronger and can protect every Indonesian without any exception. To end my brief remarks, I would like to express my deepest gratitude to the speakers who have taken time to attend this discussion and important meetings. I also invite all participants to actively participate in active discussion, discussing policy recommendation for improving the CKN program. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you so much, Mr. Adi, for the remark. And continuing the event, ladies and gentlemen, is also a welcome remark, which will be delivered by the T20 Executive Co-Chair, the Institute for Economic and Social Research, Faculty of Economics and Business, Universitas Indonesia. Please welcome Madam Riatu Mariatul Kiptia.
Thank you, Rizky. Hello.
Hello, Madam. We can hear you.
Okay, it's clear. Okay, thank you. Hello, colleagues, ladies and gentlemen. Good evening and greetings from Jakarta. Hello as well, Honorary Pak Adi Budiarso from Fiscal Policy Office, lead chair of the Task Force 6, Professor Hasbullah Tabrani, my colleagues from CHEMS, University of Indonesia, and speakers and participants in this the second day webinar. My name is Riatu Kiptia, Executive Co-Chairs of the T20 Indonesia. I would like to welcome all of you to the second day of this webinar on policy area of how putting people at the center of the health system, advancing health financing, strengthening primary care, and engaging public and private sectors. This webinar is joint collaboration between T20, Task Force 6, one of the 9 task force coordinated by the CHEMS University of Indonesia and led by Professor Hasbullah Tabrani, and InaHEA, Indonesian Health Economist Association, and USAID. From this recent COVID-19 pandemic, countries are learning from experience to mitigate and respond a working intervention in dealing with existing health crises and reflecting on how intervention not only depends on the national, but also up to the local level. And it is also not only at the country level, but also the need of global coordination. And it is also should be put in the perspective of the people affected by the health reform policy. The G20 as forum among G20 member countries vary in terms of investment characteristic and long-term planning of its health sector. The low and middle income countries may not always has adequate public funding and tend to underinvest its health sector. And as can be learned from this recent COVID-19 pandemic, the recovery process need to be relatively conducted in the similar phase to be effective, including addressing the need of innovative financing to improve health insurance policy to attain the objective of universal health coverage. Within the T20, we take a note, we are currently formulating the T20 recommendation from the policy brief notes and from the task force synthesizing from this discussion as in this today of this task force webinar. The task force 6 T20 has close discussion with the health working group under the SERPA and the finance tech. Hopefully it will provide a working and relevant solutions for the G20 in the context of health finance reform for the national policies improvement as well in the context of Indonesia. We hope strong collaboration from this discussion, and we thank you speakers from multilateral organizations, think tanks, scholars, and policymakers. Given the complex problem of making a sustainable health insurance, surely cooperation among us is needed. Again, thank you to all of you here, and hopefully to have a productive and enjoyable discussion. Thank you.
Thank you, ma'am, for the remark. Ladies and gentlemen, before we move on to the next content, we would like to inform to all participants that you may also follow the discussion by activating the live transcript feature. Hence, you will have the auto caption on your screen. And now, moving on, ladies and gentlemen, as we all know, yesterday we have concluded the first day of this webinar. So before we start the discussion for today, let's refresh our memory by listening to the summary of yesterday's points. And to deliver yesterday's summary is the Vice Chair of the Indonesian Health Economist Association. Please welcome Mr. Adiatma Siregar.
Yeah, thank you, Pak Rama. Can you hear me?
Yes, okay, sir. Yeah? Loud and clear.
Okay. Yeah, first of all, thank you, Pak Adi Budiarso and Ibu Riatu Keflia for the welcoming remarks. Much appreciated. And thank you very much as well for all the moderators and speakers, and also for the webinar team, and of course, Pak MC. Thank you very much for attending this event. And allow me to read yesterday's summary. Hang on. So yeah, this is just a glimpse of what we have learned yesterday, because there are quite some important points from day one. So if you would like to have a complete lessons from yesterday, then please visit the YouTube channel, and you may relive the yesterday's event. So just quickly, the summary for day one. Basically, we need to remind ourselves that the pandemic is still ongoing. So the end seems near, but we must remain vigilant. And at the same time, efforts to achieve USC still face significant challenges, mainly related to financing, coordination, inequity, and inefficiency in the health system. Now, the COVID-19 pandemic has taught us the importance of health system preparedness and resilience to face public health threats. It also left large uncertainty, which is why it is important to develop a unified risk mitigation approaches to face future pandemics, a focus on complementaries and greater coordination to enable faster response. But at the same time, COVID-19 also opens opportunity for people to gain traction to improve health system. In this case, investment in health, both public and private, especially private health care, is key. Now, some lessons include 1% of GDP allocated to primary health care, depending on the priorities stated by WHO. Also, budget policy relaxation and increased health budget. We also found that building resilient and people-centered primary health care can also be done through investing in healthcare workforce in public and private health care by providing training and improving the capacity of health workforce. Now, going to Indonesia, then we see yesterday the health budget realization has increased substantially. At the same time, absorption has also improved. Even if the budget is large. However, we still need close technical guidelines for implementers at the grassroots. PFM capacity needs to be strengthened, and then we still need to spend more, spend better, and we need to better orchestrate our delivery system and financing schemes. Now, from global perspective, we also learned that pandemics are a system risk issue, not solely a development issues. And COVID-19 crisis has made it clear that pandemic policy is economic policy, because we can always see the relation. Now there's a term wartime financing. So we need rapid wartime financing because time is very valuable. So as you can see from point 4, the path of the pandemic would have been very different and much less costly if sufficient and timely funding has been made available. A broader lesson from the pandemic is financing and trade of global public goods, which requires stronger multilateral institutions, equitable ownerships of all in the stewardship of global goods, rapid and adequate financing windows for global public goods, diversified supply chains with regional manufacturing. Now, lastly, we also know that during the pandemic, other disease keeps on spreading, and one of them is TB, and we have learned that TB was impacted massively in 2020, bringing coverage back to 2015 levels, and now we are fighting to reach the level of pre-2020. On that note, a comprehensive and sustainable resources allocation is needed to ensure that future pandemics would not diminish essential care coverage. And with that, I return the session to Pak Rama. Thank you very much.
Thank you so much, Pak Adi, for concluding yesterday's session. Ladies and gentlemen, we are seconds away from starting the first session of today's webinar. However, we would like to remind all participants that by the end of the discussion, we are going to open an opportunity for Q&A. So if you'd like to ask a question, please drop your question using the Q&A feature. Ladies and gentlemen, let's start the first session of the day which is a panel discussion session under the title of Role of Private Sector Towards a Resilient Health Systems, Lessons from COVID Pandemic and Beyond. And to lead the session is our moderator, who is currently the India Country Director for Access Health International, a not-for-profit organization dedicated to improving access to high-quality, affordable healthcare worldwide. He also serves in leadership roles for two organizations that work to develop affordable, innovative medical device technologies, Chairman and MD for Relicis Medical Devices, and a managing partner for Insumed LLP. Throughout his career, our moderator has worked to evolve models of healthcare to make healthcare high quality and accessible without compromising affordability. So without further ado, ladies and gentlemen, let's welcome our moderator, the country director at Access Health International, Mr. Krishna Reddy Nalamala.
Yeah. Thanks from at the outset, I would like to thank Indonesian Health Economic Association for giving this opportunity. Being a co-chair of T20, I'm privileged to get insights from very deliberate discussions that are going on across the 10 policy areas. Carrying forward yesterday's discussion, this session will focus on how we can leverage the private health sector to strengthen the health systems and make them more resilient. I think all of us understand that most of the countries have evolved into mixed health systems. That means there is a public health system, there is a private health system. In all aspects of the healthcare delivery, I mean, right from whether it is research and development, whether it is manufacturing, and whether it is supply chains or healthcare provision or health insurance. So all aspects of the health system, which are vital for the strong performance of the health system, there is a significant contribution. However, since the private sector has evolved, especially in the low and middle income countries, to meet the unmet health needs of the people, the evolution has been little fragmented, unregulated, uncoordinated. That is evident also during the COVID pandemic. I mean, while the private sector contributed significantly to the response during the COVID pandemic, but it also was evident, unlike the public health system, where there is a command control system, there is an organization structure, there are policies and the procedures, the private health system lacked that coordination across the entire sector. And also there was engagement between the public and the private systems. There was a deficit. So there were a lot of learnings from this COVID pandemic that the private health system is as equally important as the public health system. And more importantly, there is a requirement of spirit of partnership between the two sectors, the public sector and the private sector, for a shared objective of resilient health systems, which to secure the health of the people. So with this brief background context, today's discussion will focus. We have 4 eminent speakers on the panel. I should be excused if I mispronounce the names of the panelists. So we have Daya Saminarsi, founder president for Center for Indonesia Strategic Development Initiative, that is CISD. Welcome Daya. And we have Ayako Inakaki. I hope I'm pronouncing it properly. She's the director.
That's right. Thank you.
Thank you. She is the director of Southeast Asia Department of Human and Social Development Division, the Asian Development Bank. Then we have T.S. Croisen, the venture manager of Connected Primary Care Solutions. And we have the fourth panelist, Dr. Raghuram Rao, Joint Director of Tuberculosis, the Central TB Division, the Ministry of Health and Family Welfare. We have a larger information for each of the panelists on the bios which are displayed, but I thought we should use the time for more discussions and the things. So I will straight away go to there, especially to speak on the lessons learned from the COVID pandemic, both in the low and middle income countries as well as the high income countries, how the primary healthcare actually performed. There were a lot of reforms which were taken mid-course of the pandemic as a response to absorb the shock. Also, a lot of reforms were not taken as a part of the pandemic. While the primary healthcare was responding to the pandemic, the primary healthcare system itself was vulnerable. The frontline health workers were vulnerable for sepsis. They were vulnerable for financial hardships. So we need to address from both ways. How do you protect the primary healthcare system from these vulnerables? Then how do we strengthen the primary healthcare to secure people's health? I think that is the primary objective, but this is the secondary objective. I think these are some of the topics, and more so the private sector engagement in the primary healthcare, especially because it is a highly fragmented, and some of the emerging disruptions in terms of the aggregator systems, the platform systems, whether they can bring about a change in the private sector participation in the primary healthcare. So some of these issues, over to you there, I think, to deliberate on these issues related to the primary healthcare and the private sector engagement.
Thank you, Krishna. Good evening, good morning, and good afternoon to colleagues here, distinguished fellow panelists, and also participants joining in to this webinar. I will share a few slides just to help expedite and ensure that the context is done, is being caught properly by everyone here. So everyone knows we are all now still in the pandemic, trying to survive from the same storm, but unfortunately we are not in the same boat. The divide and inequity during and throughout the response or acute phase of the pandemic has shown clearly that some countries or richer countries have shown a larger loss of life during the years, 2.5 years, going on 2.5 years. However, they are more in the capacity or have the modality to ensure that all COVID-19 measurements and tools are being brought quickly and efficiently to their population. However, in LMICs and also in least developed countries, although lives lost are also many, the same service or the same privilege we cannot say that it's being accepted by countries in LMICs, and even more so in the least developed countries. Before I jump into the examples being done in Indonesia, I would like to provide some context of three different countries: Vietnam, Costa Rica, and South Korea. All countries have they share the similarity of investing quite early on in the primary healthcare system, in the health system as a whole, in their national health policy, and each have learned that, especially Vietnam and South Korea, have learned and taken the lessons from previous epidemics such as MERS, where they deploy and activated their primary healthcare system to an ecosystem to ensure that communities are being served and that health system remain intact. In Costa Rica, they have a higher spending on health. They invest more in health, and as a consequence, it shows that they have a higher immunization rate and they have better health outcome than their peers. They also have community health workers, associated community health workers, who is being cared for as an expert or a proxy of the health workers. And there is some serious investment being done to the health workers in Costa Rica. Now let's jump to Indonesia. I will quote from the editor of The Lancet, Dr. Richard Horton, who in 2016 said that Indonesia is the least represented voice in the global health. The country is tended to look inward, not outward. However, we have a population of almost 300 million people, and that is also in the eyes of the global health, that and in particular in Asia, that is a modality of its own. We are lacking. Indonesia is known to not have a strong voice or representation in presenting evidence from community or grassroots level interventions and action. Not only in primary healthcare, in other areas as well, but more particular in this time in the pandemic. More particularly, we need evidence and examples of grassroots interventions that can be upscaled or replicated by provincial government, subnational government, or even by the national government. And also it can provide the voice that Indonesia lacks during this period, pre-pandemic, into inputting the global health into what Indonesia can do in health system strengthening, in particular the transformation of primary healthcare. I will jump right ahead into the two collaboration that CISB is currently doing and has been doing since the early phase of the pandemic with the provincial government of West Java, which one is PUSPA, called Puskesmas Terpadu and Juara, and the other one is PRIMA. PUSPA has a focus on intervention and strengthening and transforming health facilities at primary healthcare level, at also strengthening the health workforce and creating primary healthcare as an ecosystem, as an integrated ecosystem. In it, we have the PRIMA, which focus on the community health workers. So PUSPA and PRIMA is actually the primary healthcare ecosystem, the ideal primary healthcare ecosystem that we should achieve if we want to be more prepared in the pandemic. Elements of the of strong PHC transformation in community health workers, in deployment of a health learning platform, and utilization of digital health to prioritize, clearly prioritize on vulnerable population, and thereby addressing the issue of inequity at the communities and within the health policy are the three key pillars that being deployed, employed, and executed in PUSPA and also in PRIMA. For community health workers, the role of community health workers is educating, monitoring and reporting outbreaks from the community level, which is captured directly in the dashboard. That's the utilization of the digital health. Health learning platform is being utilized to ensure that health workforce and community health workers have up-to-date training and capacity building required to strengthen and transform the primary healthcare. I would like to take note by of the utilization of a dashboard reporting system, which enable community health workers and health workforce to do population mapping, data integration, as well as analysis of data being captured or extracted directly from the community. It focuses on gathering and analyzing data to improve service quality at the local level. So if we take the context of the pandemic happens in the community and it should be resolved directly in the community. but data should be reported either to the public or to the district health office or to the subnational government and even to national government at real time. I would like to close by saying that what Puspa and Prima is trying to do is actually to ensure that one, the voice of Indonesia can be inputted in the pandemic and response and also preparedness. Second, we take the evidence that we gathered from public facilities, public health facilities, and we utilize that to ask and to reach out to private health facilities, and with the hope to integrate public and private sectors in the primary healthcare. This is what we call transformative primary healthcare. We recognize the intersectionality of health, welfare, protection, and digital technology. And of course, in the end, this can be a tool for policy advocacy and policy recommendation that the government, both national and subnational, that we needed at this time. I thank you and would love to clarify further on the Q&A session. Thank you.
Thanks, Daya. I think for excellent summary of the role of the primary healthcare and compelling demonstration of the example of the countries which invested in the primary healthcare and how they performed. So the correlation of the outcomes, there was a direct relationship with investment into primary healthcare and strong existence of the primary healthcare. So it was not the income of the countries, but their investment into the primary healthcare. I think that is brought out very well in the presentation. The second element that is brought out is the emphasis on information systems, especially to track the quality of the services, to track the local needs of the people, and then design services for the local needs. The third element you have brought out also the need for engaging the private sector, because the government alone will not be able to do the primary health care. But institutional mechanisms to engage the private. So can you give any examples of any one of the countries that you studied? Is there an institutional mechanism of a coordination and collaboration with the private sector and the public sector in the primary healthcare, so that they are prepared to respond in a unified fashion?
I think we can look to lessons as well from Thailand, where they have already integrated the care from public and also from the private. And the regulation that they use is very strong. They put the transformation of primary healthcare in their constitution. So perhaps that is the benchmark or the level of objective that we should aim for if we are going to really transform the primary healthcare. I would like to add that using or engaging the public sector alone only reach out to 50% of the population in Indonesia's case. Where in areas that densely populated, such as West Java, the population remain heavily relied on the services from the private providers. And I think this is a key element if we are talking about the pandemic preparedness, and it is an epidemic that spread in cities, and cities with dense population usually remain highly reliant on private service delivery. So I think integration between public and private health services is key if we are talking about pandemic preparedness, and investment of the government or investment from other stakeholders should also look into investment into private health service delivery.
Yeah, just two more points. I think one is on the role of the telemedicine in the primary healthcare, because the worldwide there was a sudden disruption and use of the telemedicine, and the policy regulation of the telemedicine as we go forward into the new normal. That is one aspect of it. And the second aspect is a lot of discussion is happening on innovative financing to encourage private investment into the primary healthcare, where the public healthcare may not have the fiscal space to invest, whether it's a blended financing and other philanthropic financing. These are the two elements I thought I will elicit opinion from you.
I agree, especially that we need private sector to want to invest in primary healthcare, and that also requires another regulation that is enticing enough for the private sector to jump into investing in primary healthcare, a sector which usually is heavily invested by the government alone.
Thanks, Dia. I think thanks for the wonderful comments and insights. I now move on to Ayako. I think the next issue in terms of, while we spoke about the relevance of both sectors, but how can they partner with each other? I think what are the models that are working in different countries, and what are the challenges that different countries might have faced when they try to work as a partners? I think a lot of countries have been going through this journey of public-private partnerships. Some countries had very successful models, but certain models, there were a lot of challenges of integration, especially when they try to come together between the people. I would like to get insights from you on some of these elements of the public-private partnership. Ayako, over to you.
Yeah, thank you very much. And then I think following of what Ibu Dia says, let me maybe share my presentation. I have only 2 slides. Okay. So, answering to a question, it's really on lessons learned from COVID-19 and the private sector engagement in Southeast Asia. So what happened that in the ongoing pandemic, obviously the governments were overstretched by the limited capacity in the health system, and at the same time the private sector obviously saw an opportunity to contribute to how to address the urgent COVID-19 response. One of the private sector engagement, including the public-private partnership experience, varied really across countries. But one common thread that we saw in Southeast Asia was the significant presence of the private sector donations, as well as the corporate social responsibility initiative. So instead of elaborating anymore, I thought it was probably much easier if I give you some example in several countries in Southeast Asia. For instance, in the area of PCR testing, in the Philippines at the beginning of the pandemic, obviously there was a real shortage of availability of PCR testing and capacity. So there was a task force that was established between the Philippines leading private companies, NGOs and business group, and the government led by the Interagency Task Force for COVID-19 response. They established this task force called the T3, it Test and Trace and Treat, to expand the country's PCR testing capacity. In Indonesia, there was this Nama Foundation operated mobile PCR test lab in cooperation with the Jakarta provincial government. When it comes to the COVID-19 vaccine supply and distributions, in Cambodia, which was a strong leadership, that we saw from the government side, and they were able to get about 9 private sector donations for vaccine procurement worth of about 19 million US dollars. In Indonesia, the quite famous one is the Vaksinasi Gotong Royong program with PT Bio Farma, which is the leading pharmaceutical company, and the private businesses. allow the private sector to import and distribute their own paid for vaccine to their employees and their families. And it's worth noting about this GRAP Indonesia's collaboration with the Ministry of Health to provide this drive-through vaccination center across the countries. Back to the Philippines, this T3 task force, DC private partners supported the procurement of vaccine, the vaccine delivery, and the data management. When it comes to the health application, in Lao PDL, the Lao Susu application is the country's national health surveillance application. It was developed by a local software company with the Ministry of Health, Technology and Communications. Back to Indonesia, the Peduli Lindungi, I hope I'm not pronouncing it too wrongly. And I think many of you residing in Indonesia have used that. This official application used for the COVID-19 digital tracing effort, jointly developed by the multinational firm PT Telkom with the Ministry of Communication and Information Technology, the Committee for the COVID-19 Response and National Economic Recovery, the Ministry of Health, and the Ministry of State-Owned Enterprise. Thailand, the Thai Chana contact tracing application developed by the Krung Bank and the government has emerged. Now, providing a safe quarantine facility and field hospital was also an urgent need during the pandemic. In Thailand, we saw 10 hotels and the Bangkok Metropolitan Administration set up what they call the hospital with 4,400 beds. The Thonburi Healthcare Group with the Ministry of Public Health and the Loyal Thai Army set up 3 field hospitals with about 300 beds. Back to the Philippines, these 3 private partners established the quarantine facilities, particularly for overseas Filipino workers returning to the countries. So because of this urgent need, I must say, but though it was a sort of good model of private sector engagement, as I say, it was a lot about donation, corporate social responsibility initiative. We cannot say that this is perhaps what we may not call official sort of a formal norm structure of a PPP that include obviously the procurement and the contract part of what's all a PPP mechanism is about. So moving on, so now how the countries can build on this heightened private sector engagement during the COVID-19 to explore different PPP solutions for different needs. So as all people who are really familiar with the PPP models, we can probably divide PPPs in the health sector to be classified in 3 categories. One is the health infrastructure PPP, which is the private sector is engaged for creating and maintaining infrastructure. And often this is bundled with the non-clinical operations. One example is the Turkey hospital PPPs, as well as the Philippine General Hospital plan PPPs. When I say plan, is because the transactions has not been really firmed up yet. Now, the second type is the clinical service PPP. The private sector is primarily engaged for providing clinical services, these clinical services in some specialized area. An example is the Philippine dialysis scheme in the National Kidney and Transplant Institute. And then in many countries, we have example of the radiologic imaging and radiotherapies clinical services, right? The third category, which a little bit more difficult perhaps, is a combination of health infrastructure and clinical services system PPP. But the private sector is responsible for the health, including prevention of a defined population. Here is the example of an ongoing PPP project in Guangxi, where both the government and the private sector are providing elderly care services. Though yet again, because of the pandemic on these particular cases, the implementation unfortunately has been delayed. Now, perhaps, when countries go into the selections of the modalities, so what is really the needs of these PPP project proposals? So when it comes to the infrastructure PPP, the question is, does the public entity have the required human resources and staff to operate that? If yes, then infrastructure PPP is probably a good model. When it comes to the PPP for clinical services, the question is the infrastructure available? And if yes, the clinical service PPP is probably a good model. I think the challenge comes when there's no infrastructure available, and then perhaps there's no staff available. Then the health infrastructure and clinical services PPP may come in. But I think probably the basic question is that will the PPP project be able to provide these intended services? Then I think the question will move into then what could be the enabling environment so that, some of these PPP projects could have a success there. Maybe, I stop here, and I don't know whether there's a specific question that you want to ask at this stage, or perhaps, some of the other colleagues can answer these questions.
Yeah, thanks, Ayako, I think, for giving the right perspective on these public-private partnerships and also the practical solutions in terms of the models. Just one or two comments before I move on to the next panelist. One is whatever the lessons that happened during the COVID, and while we translate them into a normal state partnerships, during a crisis, should there be an institutional governance mechanism where there is a constant dialogue between the governments and the private sector in terms of responding when there is a crisis? This coordination in terms of pooling up of the resources, because what we saw is some of the facilities getting overwhelmed and some of the facilities not getting used. It is because we cannot keep surplus capacity in anticipation of a crisis because it becomes inefficient. But when you have to pool the private resources and the public resources, you need to have transparent data sharing of what infrastructure each has and what human resources each has, what capacities each has. So when there is a crisis, there can be pooling up of these resources. So just I want to comment on the governance mechanisms in terms of institutional mechanisms, a periodic or integration of some of the private sector representatives on the policy making committees. Thailand has a good example in that. Just a comment on that, because unless there is a constant engagement to build trust during crisis, sometimes becomes difficult.
Yeah, I absolutely agree. And if we look at, the coordination mechanism that has been set up, really during the pandemic, and then I wish that, some of this very strong coordination or interagency task force that bring together government and private sector, including at least the effort for data sharing on the existing resource and facilities and logistics, could have been maintained. We all know that in reality, these are difficult, mechanisms to sort of to make it sustainable. So I fully agree with you that it should be really a very strong coordination mechanism. So perhaps, so this governance mechanism or institutional coordinations mechanism, this is not something that even, learning lessons for the pandemic, it could just be born as naturally. So I think it's extremely important to invest in a sort of longer term dialogue, so that at the end of the day, what is important is, for instance, the presence of policies or law enabling the public-private partnership. And here I'm not talking only about the formal PPP structure, but a coordinated mechanism whereby government and private sector can collaborate together. So these policies and law are really necessary. It includes these laws on universal health coverage and also procurement laws that allows PPP, and such as those existing in Thailand or the Philippines. Perhaps if I may go on this comment, I think there's a strong government purchaser in the health sector, including the National Health Insurance Organizers of Ministry of Health, allowed to enter into this purchasing agreement with the private sector. And those are present, for instance, in Indonesia, Philippines, and Thailand. So those are also a sort of enabling factors that we need to consider. And the third one, I'm really talking more from the private sector, but the private health sector capacity and the willingness to engage and contract with the government. And this what we have seen during the pandemic. So it's to really to encourage the private sector to not to wait for the governments to come, but really strengthen their capacity to and willingness to approach the governments to actually ask for a much better coordination mechanism. So perhaps those are the 3 points that I would like to mention.
Thanks, Ayako. I think I'll move on to the dais. I think moving on to the other dimension of the private sector. The private sector, which focuses mostly on the personal healthcare, the public sector focusing on the population healthcare. And the business ethic of private sector is maximizing the returns to the shareholder, whereas the public sector has a social responsibility to the society it serves. So addressing these conflicting things, but how do we reconcile the business ethic versus the medical ethic versus the public health ethic? Over to you, Thais.
Yes, thank you very much, Krishna, and thank you to the organizers for inviting me. I'm very happy with the topic of private sector related to UHC, because in many cases we see that the private sector is not invited at the table when the topic of universal health coverage is discussed. So I think it's already an achievement that the private sector is explicitly invited to this important event. Maybe a brief introduction. I represent Philips. Now, some of you may know Philips as a company that sells light bulbs and televisions. That is no longer the case. Philips has transformed into a dedicated health technology company. So we are one of the largest providers of health technologies around the globe. And to your point, Krishna, about shareholder value and let's say value for populations. As Philips, we certainly try to bridge those two. So, of course, we are a public company. We have shareholders that expect a certain return on investment. But equally important to us is our mission. We defined a goal to improve 2.5 billion lives annually by the year 2030. And every year we measure how we are progressing against that goal, and we publish those statistics in our annual report. And in fact, as part of the 2.5 billion lives that we aim to improve in 2030, we have also made a commitment that at least 400 million lives of the 2.5 should be in what we call access to care countries. those are the countries in the world where large parts of the population do not have good access to basic healthcare services, which in total is about half the world population. My responsibility in Philips is I'm leading a venture that is called Connected Primary Care Solutions. So as the name already suggests, we develop innovations for primary care with a focus on access to care countries, and increasingly those innovations are connected, digitally enabled innovations. Maybe picking up on the topic of COVID-19, which of course was also discussed by the other panelists. What did we learn from it as Philips, and what did go well? I think there are two main learnings for us from the COVID-19 pandemic. One is, and it was already mentioned by the other speakers, is the breakthrough of digital health and especially telehealth. A lot of things that were considered impossible before the pandemic suddenly became possible because people no longer could or wanted to visit health facilities. So we have seen an enormous increase in the use of telehealth. And I think telehealth holds the promise of achieving universal health coverage in a cost-efficient manner. So I do hope that we will continue to see technology, and especially internet technology, to improve access to healthcare services, and not just access, but also things like clinical decision support to help healthcare workers in proper diagnosis, etc. So that's one learning. The other learning, which I thought is a very interesting one, at least from our perspective, was that when the pandemic started, we were suddenly confronted with an enormous demand for certain equipment that is critical in treating COVID-19 patients, such as ventilators. So not just us, but all the producers of ventilators across the globe suddenly saw their demand multiplying. And the big risk was that those products that were produced would go to whoever would pay the highest price, which would probably have been rich companies and rich countries around the world. But in this particular case, the international community came together with the main manufacturers of such equipment and agreed on a model whereby products were distributed to those countries where the need was highest. So I think that was a good example of how private companies can work together with international community and local governments in making sure that there was a fair distribution of technology that was so desperately needed to treat patients. Maybe back to you, Krishna, to see what further questions you may have for me.
Yeah, so one or two questions. I mean, especially since the private sector tends to focus on value customers, whether it is tertiary care or high-end procedures or technology-based procedures, versus the underserved areas and underserved diseases, neglected diseases. So how do we reconcile this preference to value customer versus the responsibility of equity and the geographic equity? So this is always a question as to how can be a solution between the public sector and the private sector to bring a balance between the business requirement and the medical requirement, and still make it possible to go to the underserved areas or underserved sectors like the preventive care or the primary health care. What are the innovative financing solutions or innovative contracting solutions between the public payer and the private provider? So these are some of the areas I think still needs to be explored in terms of bringing in the private sector as a key contributor to underserved areas. This was one question I wanted. And second question, of course, was the emerging role of the aggregator platforms to aggregate the fragmented private primary care. What is your view on this aspect of it?
Sure. Yeah, okay, thank you. Yes, to the first point, that is indeed a very relevant question. I think for most private companies, primary care is not a very attractive market from a financial perspective. The risks are high, it's very fragmented, the return on investment is not always that good. So a lot of private companies will shy away from primary care. Whilst at the same time, I think private sector has a lot to offer in primary care when it comes to innovation, management capabilities, sustainable business models. So I think what is important for to attract the private sector to invest more in primary care, I see two elements, and they are related. The first element is incentives. Private companies are very sensitive to incentives. I always say, if you create a market, companies will go for it, and they will try to win some of that market. So I think incentives are very important, and incentives can be a market, a demand, or for instance, as we sometimes see in the pharmaceutical sector, an advanced market commitment where a government or a donor will say, we want companies to develop a certain drug for maybe a neglected disease, and developing that drug is not commercially attractive enough for a pharma company to invest in. But if someone says, okay, if you develop the drug and it meets certain criteria, I will guarantee that I will buy a certain volume at a certain price. In that way, the investment is de-risked, and the company, that could be an incentive for the company to invest in developing that particular drug. Now, we haven't yet seen that mechanism in the health technology sector where Philips operates, but it's something that we certainly welcome. Because yes, some innovations are too risky for our shareholders, but when incentivized, we will definitely be more than happy to make those investments and to, of course, still take part of the risk. So I think incentives are important to attract the private sector. And almost the other side of the coin is a level playing field. Because as a result of the private sector not being very active in primary care, we see that primary care has become the domain of governments and donor-funded NGOs. So we see a lot of innovation going into primary care that is donor-funded and that is provided for free. That means for us as a private company, that's not an attractive market, because when we cannot compete against products that are provided for free. So when I talk to donors, I always make a plea that do not give away products for free, but rather give an incentive so that the private sector can maybe develop those innovations. And most private companies, they have the ability to make it more sustainable, to do it at scale. So you don't end up with these unsustainable projects. So I think those are the two elements that are important to us, incentives and a level playing field. To your question about aggregation, that is very true. If I look at primary care, and of course it differs between countries, typically there's a lot of scale in the public sector. Public sector, the governments run very large networks of primary care facilities. And on the private side, there's not a lot of scale. You find a lot of scattered operators operating one or two facilities. And I think that is not desirable from an economic perspective, but also not from a quality and public health perspective. So what I do expect and what I see happening in some parts of the world is that the private sector goes through a process of consolidation, where we see larger networks of primary care facilities being created, sometimes out of hospitals, private hospitals that decide to start setting up outreach clinics that are closer to their customers, sometimes networks that are purely primary care. And so we are working with some of them to help them set up their business. And I believe that will bring a lot of benefits. Again, it will improve efficiency, it will improve quality, but also coming back to my predecessor, it will also make it easier to organize that public-private dialogue around healthcare.
Mas, ini dihack orang kali ya?
I think there was some disturbance.
Yes.
Thanks, Trace. I think for valuable comments on various aspects. As we there is a time pressure, so I will move on to the next panelist, Dr. Raghuram Rao, Joint Director, Tuberculosis Central TB Division. Dr. Rao, I think because the tuberculosis is a classic example of how essential services. Dr. Rao is here.
Yeah.
Since the tuberculosis being one of the key disease segment, which is a classic example of how essential services got affected during the COVID pandemic. And in this context, we would like to hear your experience in terms of how you have been able to sustain the ongoing eradication program, actually, which India has set it up as its goal, and how the private sector has played its role, and how do we envisage going forward to synergize more with the private sector so that the goal of elimination of tuberculosis, I mean, the largest burden of tuberculosis in the world, how you are planning to achieve that from the government's perspective?
Thanks, Krishna. And just share my screen. Just a couple of slides, which will help understand the burden of TB. One is that the private sector in India has a very, very significant space in the health sector, and almost 50-70% of our people get in touch. The first point, with the private health sector. Even the prevalence survey we just concluded, during 2019 to 21, in the midst of COVID, almost half of our patients were seeking care in the private sector. And it's not that they just seek care, they even do provider shopping. They visit at least 3, and they spend a lot of time, almost 2 months, by the time they are finally diagnosed and put on treatment, and spend a lot of money on that front when they are jumping around in the private sector. And in terms of program, although it has been a program which first started in 1962, but it was largely focused on the public sector. And the last 5-7 years, we have had a huge impetus with making sure that we reach the private sector. And you can see the numbers, and since 2014, we have almost jumped 6-7 times in terms of the number of cases that are getting notified for the program by the private sector. And India, we are estimating around 2.6 million cases annually to occur, the incident cases. And we were able to capture almost 2.3 million in 2019, that was pre-COVID. And then with COVID, we had a huge impact, and our services got disrupted for a brief period. And being the first year in 2020 with the Delta wave, we had a tough time. Everything was new, the pandemic, the lockdowns, and all those measures. The public sector had a big impact, and on the everything non-COVID basically had an impact in the health system, including in the private sector. There was a fall. But then in year 2, in spite of a very large Delta wave, the graph you can see is not coming down, it's only going up. And this year, we are probably overshooting even pre-COVID levels in terms of finding all cases and putting them on treatment.
We are not seeing the graph. Can we go to the graph?
The slide is not moving?
Yeah, at least.
Okay.
Yeah, now we are able to see.
Now it's visible? Yeah.
Yeah.
So like I said, we were reporting around 1.5 million cases in 2014. And now we are, in 2019, we reported almost 2.3 million as against an estimate of around 2.6 million. And we, in the current year, the trend that we are going, we will probably land up overshooting 2019 levels also. And the private sector numbers, if you see, we are probably going to overshoot even 2019 levels, and almost 0.7 million cases would be notified by the private sector as of now, in the current year, and that's almost 30 to 35% of the total cases that are getting notified is coming from the private sector. So that's the magnitude of the private sector and its role in TB in India. And there was a systematic policy level interventions that we did, right from being a Schedule H1 drug. So it's something which cannot be sold over the counter. So strengthening those regulations, enforcement of that, and then putting investments with human resource at the district level. That's at the at the national level, and then we have states, and then the district level. So at that district level, putting in dedicated human resource, and then adopting enabling environment by making the private sector, the patients who seek care in the private have access to the free drugs and diagnostics that we have under the national program. And so that's in 2017 where we made the NSP with the target of trying to achieve the SDGs 5 years ahead of the timelines by 2025. So that NSP gave the maximum push, and the investments also came in. And we also went with the carrot and stick approach for the private sector, where of course it was made mandatory that the private sector notifies the cases that are seeking care in the private, but at the same time we also introduced incentives for the private sector and for the providers as well as for the patients. So that gave a good push in 2018. That scheme was introduced in 2018. So you can see the cases jumping from 0.4 million to 0.6 million. And then we put in an interface agency, which was acting as a bridge between the public sector and the private sector, and helping the private sector to access the free drugs diagnostics, helping them notify that into the central IT system that we have under the program, and making sure that the incentives are delivered. So that's where. And then we also in the last year put in technical support units at the national level and at the state level to help the states and the district administrations get these interface agencies on board and help them deliver these services well. So that's the investments that we did in the private sector, and we had the results. But the role that private sector played even during the COVID pandemic in terms of making space for the patients to be able to ensure uninterrupted service delivery, be it for continuation of drugs during lockdowns or having access to diagnostics, and making sure that we were able to find and provide uninterrupted services during the pandemic state. The private sector played a huge contribution, not just in the cases that were seeking care in the private sector, but also to help us fill in gaps in the public health system also. So that's the role that they are playing for us, and it's been a very probably I would say best practice from our side, where different innovative models through interface agencies to create that enabling environment for the private sector for notifying cases and managing those patients, including the public health actions that were required for the cases that were taking treatment in the private, be it for contact tracing or making sure that comorbidity management is done and the adherence support that is required for the patients to ensure that they continue and continue the treatment and are cured. So that's the kind of work that we have been able to do in India. And of course, it's not yet done because the road having advanced the SDG targets for ourselves, we have a huge work in front of us in the next 2 years. And hopefully now the systems are resilient to handle any pandemic of this sort. And you can see the way we were able to scale up our interventions in spite of COVID. So that's something which I wanted to share with all of you all, and we'll be happy to answer more questions. Thank you.
Thanks, Dr. Rao. I think this illustrates how public-private partnership can be done actually to achieve an objective, the audacious objective of eliminating tuberculosis. He also brought out very critical factors in terms of what works in the partnership, both the carrot and stick model, as the previous panelist also has indicated, how incentives are utilized innovatively to engage the private sector in achieving the goals. The second element that is brought out is the need for that bridge between the public sector and the private sector. A third party which can bridge, like the technical support units, which could bridge and eliminate the distrust that naturally exists between the two sectors. So there is a need for that type of institutional mechanisms to bring the people together and address some of the misunderstandings between the two sectors. And the third element I think Dr. Rao has brought out is the importance of having a robust registry data, the health information system and the robust registry data. While it is a disease-specific robust IT system, but I think each country, there is a need for national health information system, interoperable, and so there is a need for making the health systems resilient and more disease surveillance, which is dynamic and alive, rather than the traditional systems which have a lag period between the onset of epidemic to actual notification. So this brings you another dimension of public-private partnership in terms of how does the private sector actually is willing to share the health data of the people for the greater public good. I mean, these are some of the elements I thought are important from the perspective of the public-private partnerships. I think I would like to thank all the panelists, and then there are certain questions from the various participants in the panel. If I'm exceeding the time, please set up the clock so that I can be conscious of the time. I will, I think, read up some of the questions here. There is a question to that. I think what kind of intervention during pandemic that you think is important to strengthening the primary health care so that we can prepare in the future? I think this is a very large question, but Daya, would you like to respond to this? I think I'm not able to see there, but then we will take up the next question. Looking at the national health accounts in Indonesia, primary healthcare has been losing ground since JKN start. What happened here and what can be done? I think, again, this question is to Dia, who is not here. There's a question to Ayako from anonymous attendee that what is the key policy framework to encourage more public-private partnership in health? Or what is the key enabling factor? Ayako, over to you.
Yeah, no, thank you for the excellent question, and I think Krishna, you have already mentioned some of the enabling factors such as the data sharing, how both it's really how private sector can collaborate more with the public sector to be able to share the data. So it's the interoperability of health information system, and that needs to be elevated really at I must say at really if possible at the national policy levels. So how, for instance, even at the health facility level, all the public and private hospitals would agree really to share the data that they have. And I have mentioned, a few things, much at the broader level. It's really, can we encourage countries to have a robust, laws or policies, or it could be a PPP laws or PPP regulatory framework that actually put the regulations on how public sectors and then private sector can collaborate in few of the area that have been mentioned by several speakers here. Whether it's on infrastructure, whether it's on clinical services, and on data sharing. So I think this is, the stronger the laws or the policies on public-private partnership, and I think it's easier for the both parties to come together. I know that it's probably easy to say than to implement. I think in our own experience, not so many comprehensive or good PPP deals have been really implemented in a sort of effective manners, excluding obviously what happened during the pandemic. And I think someone I think mentioned about it's to integrate that PPP coordination or PPP mechanism, how to enable this mechanism into really integrated into the UHC laws and implementation guidelines. I think this is also very, very important. And I think, we mentioned about a supporting mechanism to sort of bring private sector and government together, this institutional mechanism. I think it's quite important. If that's really the case to be, is whether development partners or outside institutions can also provide a support to set up such mechanisms, such as providing technical guidance, support for the transactions, advisory services, both to the government as well as supporting the private sector on how to coordinate with the government's counterpart. So perhaps those are the sort of enabling factors and policies that could help in having more private sector engagement. I'm not saying that it's going to work always, but at least it provides a framework or opportunity to for both parties to come together. I stop here.
Thanks, Sayako. Rama, how much time I have? Can I take more questions? Yeah, I think we have one question here. Do we still see inequity of benefits between public and private sector? And how can we aim towards better fairness? Thijs, would you like to go for this?
I'll give it a try.
Okay.
My question back would be, what kind of benefits are you referring to? Under the assumption that the question, the person asking the question talks about benefits as they are being paid out by insurance companies. I think that is an interesting topic. I do a lot of work in Africa, and increasingly African countries do have social health insurance systems, like I think we also heard from the keynote speaker about Indonesia. But one of the things that make these systems very unattractive for private healthcare providers is the fact that the reimbursement, the amount that they are being paid for services provided, assume that certain cost is paid by the government. So the reimbursement will assume, for instance, that salaries for health workers are paid for by the government. which is true in the case of public health facilities, but which is not true in the case of private health facilities. So for many private providers, the reimbursement levels just do not cover their real cost. And as a consequence, they prefer not to serve patients that come with a social health insurance coverage, or they will ask those patients to pay out of pocket on top of the reimbursement they receive from the health insurance. So again, it comes back to my earlier comment about a level playing field. I think you need to look very carefully at public and private, in this case, providers, and make sure that there's a level playing field between the two. Because I think in the end, patients will benefit from some level of competition. If those healthcare facilities that provide better quality care, they should be rewarded for it. Through more patients or more income. So you need a system also in the public sector where performance is being rewarded and where bad performance is being punished. And as long as that mechanism is missing, there is no incentive in the system to improve. So I think that's hopefully gives an answer to the question that was asked.
Thanks, Tess. Do we have any more questions from the participants? Yeah. So again, this question is to Tess again. What do you think can be done to make sure private sector and public sector have in line or completing each other health program and not overlapping each other? I think the question is related to how to bring complementarity rather than competition between the public sector and the private sector.
Yeah, maybe, and it's not a low or middle income country, but let me give an example from the Netherlands, where I am from. In the Netherlands, we have a very interesting system that where most of the healthcare providers are private, but they are heavily regulated by the government. And a third important party is also insurance. So in the Netherlands, we have a system where the government will define the basic insurance package. Then insurance companies can compete on selling that package to patients, and essentially the insurance company that can sell that package at the lowest possible price will probably get most patients. The insurance companies are now the strategic buyers towards the private providers, so they will buy services from those providers that offer the best value or the best quality and price. And what is very interesting in our system is that patients, whenever they seek healthcare services, they always have to pay an own contribution, even when they have insurance. So there's always a bit of a barrier for entering the healthcare system, except for primary care. If you go to a primary care doctor, there is no own contribution, it's fully covered by insurance. And that is a way to channel as many patients as possible to primary care. And those primary care doctors are now the gatekeepers for the rest of the healthcare system. Because about 90% of health conditions can be dealt with at the primary care level if it's fully functional. So I think it's that interplay between government, insurance, and providers. And it's a very delicate system where you need to look at, okay, who does what, how are the incentives so that the system as a whole will provide the best healthcare for the lowest possible cost.
Thanks, Tess. The next question is to Dr. Raghuram. It is great to see the excellent concrete example from TB program in India. Do you mind to elaborate what incentives did the government offer to providers, patients, and also private sectors? How do you monitor and verify whether the incentives are distributed accordingly? Dr. Rao.
Yeah, also typed it in the QA session, but just broadly, both for notification of case and for managing the case and reporting treatment outcomes, there are separate incentives of ₹500 for notification and 500 for treatment outcomes, and then also for the patient, we provide ₹500 every month into the bank account directly. So all these incentives are all provided through an IT system. And it's called direct benefit transfer. It goes directly into the account, and we are able to track each individual when is the next installment due, and when is it given, what happened to the previous installment. So all these things are all available as a IT system that we are able to view, and it's and dashboards for the program managers to review that is available in the form of dashboards and reports at all levels, at the national level to the most peripheral level in the health system. We are able to use that. So that kind of system is inbuilt, for doing that.
Any more questions? I don't see any more questions coming up. I think I would just wrap it up before I thank all the panelists and all the participants. It was a rich experience, the last, I think, 1 hour plus. Started with, I think everybody agrees, the importance of the primary healthcare, importance of the strong primary healthcare, and importance of both public and private players contributing to this strong and resilient primary healthcare. But how to do it, I think a lot of lessons they have to come up with. So that was, I think, one key message that came out in the first panelist discussion. And then there is a lot of discussion in terms of what type of model and institutional mechanisms that can be created for the public-private partnerships to work efficiently and effectively. I think a lot of discussion has happened, and there are mechanisms to bring these partnerships into fruition. There are experiences from which people can learn what mistakes should be avoided and what works and what does not work in various contractual mechanisms in the and I think the beautiful classification of where the partnership is possible. But most importantly, I think Alexo in his comments in the question and answer box has mentioned how the government provides the stewardship role and engages the private sector right from the policy formulation and at every step of policy implementation and at every step of the response. So that builds a natural trust mechanism between the two partners. I think that is the beginning and the key critical aspect of success of the public-private partnerships. Thijs has brought out, I think, a significant factor. I mean, unless there is a level playing field, to expect the private sector to be totally tilted towards the social responsibility at the expense of shareholder responsibility, it will not work in the private sector. So there has to be a balance between the shareholder responsibility and the social responsibility. And also there has to be a level playing field between the public sector and the private sector. I think these are some of the powerful messages that came out of this panel discussion. I think without much ado, I think I thank all the panelists for this wonderful session, and thank the organizers and thank the participants. Over to you, Rama.
Thank you so much, Mr. Krishna, for conducting the very insightful session. That's the end of the first session of today's webinar. Thank you so much to all of the panelists also. And ladies and gentlemen, all participants, before we are going to move forward to the second section, we would like to kindly ask all participants to fill out the attendance form that has been sent in the chat box, as well as the evaluation form. Please fill out the evaluation form and give us some feedbacks or inputs so that we can conduct our next event better. Ladies and gentlemen, let's continue the event with the T20 Task Force 6 Policy Brief Draft Presentation. And to guide the session is our moderator, who got his bachelor's degree in public health and master's degree in economics from Universitas Indonesia. His research interest includes tuberculosis, HIV, maternal and neonatal health, and malaria. In his previous roles as a health financing specialist under the USAID project on health policy and financing, he served as technical assistance to the government of Indonesia in regard to the strategic purchasing, costing, price setting, etc. And now, without further ado, let's invite our moderator for the second session. Please welcome Mr. Eri Setiawan.
Thank you for your kind introduction. So good morning, good afternoon, and good evening, everyone. Welcome to the second session of the Task Force 6 webinar that brings the title of advancing health financing, strengthening primary care, engaging public and private sectors. So as mentioned by DMC, my name is Aris Tiawan, and I'll be acting as moderator of these sessions on behalf of the Indonesian Health Economist Association, or InaHEA, and the USAID. So first of all, I'd like to share a bit of introductions about these sessions. Back then in December 2021 to February 2022, the Task Force 6 opened a call for abstract to invite many brilliant ideas on the global health system improvement from many countries. So the initial presentations from the abstract author was conducted in February. And now, today, we will see the top 3 ideas that will be delivered by Dr. Namrata, Dr. Abdillah, and Dr. Monica. But I haven't seen Dr. Namrata in the panelist list or in the attendance list. So she will be talking about the idea on resilient health system reform for the holistic primary healthcare. And Dr. Abdullah Hassan, he will present about earmarking health tax for sustainable universal health coverage financing in T20 developing countries. And our third presenter, Dr. Monica Herder, she will share about global public investment, or GPI. The output of these discussions from all those recommendations will be an input to the final policy brief released by the Task Force 6 under the policy area 3, which is the investment and reform of the health system to guarantee the resilience to achieve the universal health coverage. So to all presenters, we will have 30 minutes for presentations, meaning that each presenter will have 10 minutes to present in a row, and we can have a Q&A sessions afterwards, as well as the summary in the end of the sessions. And for the audience, please kindly put your questions or any clarifications along the presentations. So I think that's all for the introductions. And so I will be inviting perhaps Pak Abdillah Hassan, because we haven't seen Dr. Namrata yet. Are you ready, Pak Abdillah?
Oh, yes, Eric. Yes. Okay.
Okay. Thank you. You can also introduce your team as well. So over to you, Pak Abdillah. Time is yours.
Okay. Thank you, Eric, for the opportunity. Good morning, good afternoon, and good evening, everybody. It is a great honor for me to present our draft policy brief draft in this prestigious event. Our draft is about the earmarking the health tax for sustainable universal health coverage financing in the G20 developing countries. We are the team of 4 persons, me, Twini Handayani, Krishna Puji, and Nadira Amalia from the University of the Indonesia. Okay, next. As you know, this is the quality of healthcare globally. And there is a variation of quality of healthcare in the world. So as you see here, in Africa, there's a challenging situation. Yeah, in Indonesia also, there's a challenging situation. Next. So we analyze the challenge of healthcare in the G20 countries, and we find that different countries possess different health challenges while recovering from the pandemic and the different phases, and this is resulting in potentially increasing health disparity between countries. And our main argument is that underlying public health threat is the underfunded universal health coverage and the public health sector. Okay, next. And this is the challenge number 1 that we found after analyzing the data from the G20 developing countries. The first is underfunded UHC and emerging burden of disease. So low and middle income countries are struggling to find alternative sources of financing. Over 40% of out-of-pocket health expenditure. And then we also have the quadruple burden of disease, non-communicable disease, communicable disease, coexisted with the maternal child mortality and injuries, and also substantial burden of non-communicable disease. And underfunded UHC increase the risk of for the poor people to access health services. Okay, next. And the challenges number 2 is fragmented funding and equitable primary care service. In low and middle income countries, they are majorly dependent on the international aid for public health issues. So we need sustainable funding to fund to make sure that universal health coverage is in the sustainable situation. Okay, next. Our the challenge number 3 is about the global health disparity. This is the comparison of basic health indicator between income group from the World Bank. As you see here, life expectancy at birth in the high income is 81, while in the low income is 64. And maternal mortality in high income, as you see, 11 of the 100,000 life, while in the low income is 460. So the main idea is that health disparity is related with the income level of the countries. Next. So our proposal, next, I think we can move on. Next. Yeah, there's the 3 challenges above, alternative financing to extend the UHC funding, and then create the unified healthcare system, mobilizing financial resources. Next. And our proposal is to have the health tax, and then after that earmark the health tax to fund the UHC. So what is the health tax? The health tax is defined as tax levied on the product that have negative public health, for example, tobacco, alcohol, and sugar sweetened beverage. So why health tax? Because health tax will control the consumption of risk factor related with the NCB, tobacco, SSB, alcohol, and saturated fat. So, and then the proposal number 1 is to impose the complete health tax on tobacco, alcohol, SSB, and saturated fat. And next. And then after imposing the health tax, so the impact of imposing health tax in Mexico, in South Africa, it has a positive impact on the public health. In Mexico, after the 2 years of implementation of SSB tax, per capita sales of SSB dropped by 7.3%. In South Africa, the health promotion introduced in 2018 significantly reduced the sugar consumption. So sin tax in 6 countries could provide sustainable financing for the respective countries. Next. And then the next proposal to earmark the health tax. So we need to earmark the health tax to fund the universal health coverage, to fund the national health insurance. So taking percentage or proportion of tax, then earmark for the health financing. Okay, next. So this is advocating after we impose the health tax and then the earmark the health tax, and then how to make it come true. We do the advocating the policy proposal. So the strategy is to distribute the policy brief, the advocacy material to the influential network, opinion leader, and decision maker. And then strategy number 2 is to do the public campaign to disseminate information. Okay, next. And and then we have to prepare unified policy mechanism to implement the health tax initiative. Each country needs to develop a basic policy for imposing this, following with their standard and their uniqueness. So health tax requires 2 central costs. First is financial aspect. It is necessary to identify actors to be able to draft the regulation, and also the health aspect. Relevant ministry need to continue to voice health promotion aspect and reduce consumption of risk factor such as tobacco, SSB, alcohol, and salt. Okay, next. So I think that's all for our draft of policy brief. Your comment is welcome. Back to you, Eric.
Yeah, thank you so much, Pak Abdillah. It's very clear and great, and so timely. So I will be inviting Dr. Monica Herder to pop up on the screen.
Okay. Yes, hello everybody, and Dr. Abdillah, a great presentation, and I could not agree more on all your proposals. Fantastic. So yeah, thank you very much to the organizers and my co-participants to give me the chance to introduce our global public investment idea, a short GPI, and Pak Eri. Wonderful to be here with everybody. So I would like to begin by mentioning that the main authors behind GPI are Jonathan Glennie and Simon Reed Henry, both with who our institute, the Job Lange Institute, has been collaborating and partnering for numerous years. And Jonathan and Simon have written a paper 8 years ago on GPI, and this was under the auspice of the UN Development Program. Both have been in the development world for numerous years. And since then, GPI has been defined and redefined and talked about with several thought leaders, with experts in the development community. There have also been dialogues at UNGA 2019, where we launched the GPI officially. And we've had a Wilton Park conference in 2020 during COVID, and then several roundtables. So there has been a lot of talk. We have created an expert working group with regular exchanges over several months. And we are super happy to work with partners globally, but mostly and with a focus in low and middle income countries. So what is GPI and how would it work? Maybe we can go to the next slide. Thank you. So GPI is meant to be a finance mechanism, and this is very important. We do not introduce a new fund. We don't introduce a new organization. It is an idea. It's a way of introducing a new finance mechanism where all countries pay in, all countries benefit, all countries decide, because to pay in and to get countries in on this, we need incentives, and we believe those incentives are co-creation. We believe they need to be, they need to have a seat at the table. There will be, seat at the table means they will need to be on the board of an institution, and we have an emphasis on co-creation, and that goes beyond the countries. It goes to the civil societies as well. So in this, GPI proposes a shift in mindset, and it calls for a co-creation with all partners. I already mentioned civil society, but that also involves the private sector, which the panel before was heavily involved in. So we do believe that the governance structure needs to be a 21st century approach, and that's the lessons learned in a way. And maybe we go with this to the next slide. This is where we think global GPI can work as a global finance mechanism. So the pay-in would be through budget lines, but we do realize that low income countries may not even have budget lines. So that would be for us a new tool that needs to be established. And there are different things or thoughts that we can talk about in country spending. Could that be a portion of domestic contribution, etc.? And when you see down, all decide, that is the public, the governments and the civil society sit around the table together with the private sector. The payout, there are many different partners already. There are lots of funds and multilateral organizations that know exactly how this can work. And so again, to my point that does not need to be a proposal for a new fund. But maybe we go with that to the next slide. And here, with the pandemic and the global awareness that nobody is safe until everyone is safe, the world responded by creating Act A. And what was the biggest problem with Act A is only 15 donors provided 96% of the funding. And now that we're looking at the establishment of the Financial Intermediary Fund, the fifth for PPR, which is a fantastic opportunity for the world, for everybody. But unfortunately, it will face the same dilemma if there won't be a change of approach. And this is where we believe DPI will come in. With that, maybe we change the slides, Pak-Eri. Thank you very much. So we believe that by incentivizing countries, there will be or could be a lot of additional funding. Countries that have not so far paid into other funds and have traditionally stayed out of contributing, they would, by giving them a seat at the table, they would be incentivized to pay in and participate. So maybe you go to the next slide. This is more to the governance. We believe in a fair share contribution, sustainability of contribution, participation in decision making. This is also towards the governance. The technical advisory panel, there would be the WHO in the forefront of being a partner in that. And maybe we go to the next slide, which this is to us a model that we propose. It's a suggestion on how the governing board could look like. And we think and believe this would go in phases. So the first phase starts only with a few donors. And then in phase 2 and 3, more countries will participate. So board seats need to be bundled. And this could be done in bundling countries into constituencies, and there we would build constituencies into income levels, so that higher income countries would not compete with low income countries, and they would be all given seats according to their peers, and so it would be an equal board seat distribution. Next slide, please. So the when we establish, when the fifth will be established, the phases need to be given. There need to be phases, like I just said, the creating phase, the establishing phase, and the transformative phase. And we do insist on using all the existing implementation partners, meaning the Global Fund, Gavi, CEPI is another one of them. And we also highly recommend and advocate for additional funding and not using the existing official development aid. So the next slide, please. So the fifth needs all actors to come together. It needs co-creation. And if implemented in a DPI style, we will see a very successful outcome. And here again, the co-creation by WHO, the World Bank is certainly in there. We need governments, but also civil society and the private sector to have a seat at the table. Our key recommendations are using the DPI principles on the new fifth and to put GPI on the G20 agenda as a model and a new mechanism to finance global public goods. GPI then could also be used not only in health, but could be a template for climate, for disaster response, and also other global public goods. And with that, I really want to thank everybody for listening, and terima kasih.
Thank you, Dr. Monica. That's wonderful presentations. Yeah, I think we have some questions in the Q&A box. Perhaps the committee can share pop-up questions. Yeah, I think the first questions to Pak Abdillah. Yeah, really great presentation explanations. I want to ask about SSB. As I heard before from the current trend during pandemic, that was said that there is a decrease in sales of SSB. Do you think with these conditions implementing health tax in SSB still a suitable solutions for the problems? Thank you. Over to you, Pak.
Okay, there are two things. First, in Indonesia, the SSB consumption is still increasing. During the last 10 years, it increased 15 times, yeah, from the survey of socioeconomic survey. So the SSB in the socioeconomic survey is bottled tea water, sugar sweetened tea water, and it is increasing very high, yeah. And so this is not the case in Indonesia. In Indonesia, I think not only in Indonesia, but in other developing country, the SSB SSB consumption is increasing very, very fast. Yeah. So, and the consequences of SSB consumption is obesity and then the diabetic. Yeah. And based on our basic health research, the obesity and the diabetic cases is increasing. And also the NCD, the catastrophic non-communicable disease like stroke and other things, it is still increasing. So it is important to stop. It is important to decrease and to cure the problem from in the sources. And so it is important to for the health promotion. It is important to decrease the risk factor of NCD, that is SSB1, through the tax policy, through the fiscal policy, by putting health tax to the SSB. And yes, I think tax is very important to change the consumer behavior toward healthy lifestyle. Okay.
Thank you, Pak Abdillah. So these recommendations not only focus on the financial aspects, right, but also for the health risk reductions.
Yeah.
Thank you, Pak Abdillah. Maybe the questions can be pulled up again. Yeah, I think this question also is to Pak Abdillah. Indonesia does quite well on its alcohol tax, yet lags behind on tobacco tax and junk food tax, such as kerupuk. Why has Indonesia had such a mixed record, and what can be done?
Yes, I think, as you know, Indonesia is a Muslim country, and there is a fortunately, alcohol drink is haram. It is not allowed to drink for the Muslim. And then while cigarette, unfortunately, is not yet haram. So maybe it has an impact to the consumption, and also that's why the consumption of cigarette in Indonesia is very high. Yeah, 34% of Indonesian smoke, and then more than 60% of male adult smoke, and our smoking rate is still high and stagnant and not decreasing, while other countries, other developing countries, the smoking is decreasing. And we are advocating, we are communicating with the government on how to improve the fiscal policy in the tobacco tax, so that it has an effective and efficient impact, significant impact on the consumption. Yeah. So this is in the tobacco tax situation. We are working on it. Yeah.
Thank you, Pak Abdillah. I think the next question is addressed to Dr. Monica. What do you think need to be aware of when GPI implementation is done by LMIC?
Yes, thank you for that question. I think that it's very important that the LMICs are not competing with high-level countries. I think it is important that they are all compared with their own socioeconomic numbers. And I also believe that it is very important that we get away from this old stigma of rich giving to the poor, and that we're getting away from it is charity, and that we take really into account that there is a dignity. And I do believe if we can overcome this, there is pride in these countries they don't want to be treated as charitable recipients, and people have their own way of doing things. And it's to me, or to us, it's going both ways. That we as the high income countries do listen to the low income countries and can learn their own lesson. There completely needs to be a change in understanding how low income countries tick.
Okay, thank you. That's very clear. So wait, let us see. Another question for Dr. Monica. The WEF seems to be putting more emphasis on climate change than health. While climate change does impact on health, how do we know that there will be adequate support for health and not diverted to climate change initiatives?
Yes, also this is to us. We are working on health as well, and I mentioned in my presentation that we believe that the mechanism of global finance, global public investment can also be used for climate, and there is also overlap. So we are working together with climate organizations, and we believe that this all climate and health goes hand in hand, and we need to find a way to combine these. But of course, we have all limited. There's limited funding, and we all kind of aim for the same pot of money. And we are aware of this and try to make the point for both. There is no better. There is no health and climate. They're both equally important, and they are totally interlinked and connected. So, good question, and we're working with our climate partners on it, and encourage both.
Thank you so much. So as there's no any other questions, but we still have time, so perhaps I can share my one question in mind for both of you. So given the difference in bureaucracy system, the governance and socioeconomic structures, as well as the fiscal capacity amongst countries, what do you think the highlighted arrangements that we need to consider in ensuring that the feasibility of your recommendations? Something like maybe political arrangements or some kind of that. Thank you. Maybe Pak Abdullah or Dr. Malika can start first.
Maybe Monica first.
Thank you. Thank you. There's no doubt that all countries have their own systems, bureaucracies, goods and bads, and ways to do things. So GPI really argues for the co-creation that is key. We believe by again building constituencies that bundle the same socio-economical countries together. So high-income countries do not compete with low-income countries, and that we also say that the fair contribution must be guaranteed, where of course the high income countries will give more and benefit or get out less than the low and middle income countries. So we also believe that there are we need to have civil society on the table, we need constituencies on the board, on the civil society, multilateral organizations like the Global Fund and Gavi have shown that this is very successful, and where civil societies are on the table, those outcomes are way better. They are the ones having the connections to the local and to the communities, to the regions, and they are the ones being the conduit to the political leaders in their countries, and who then make decisions. But without civil society, but we believe that there cannot be a successful fund.
Okay, thank you, Dr. Monica. Maybe,
Yes, I think for the idea of earmarking the health tax for the universal health coverage, I think there is a trend of the health tax, tax on SSP, on tobacco, SSP, and alcohol. I think many countries, most of the countries, especially for for alcohol and for tobacco, there's already implementation on the health tax on that, on the tobacco tax and alcohol tax. But for the SSB, maybe around 50 countries has implemented in ASEAN, but Indonesia has not implemented. So we are trying to push the idea to have the SSB tax, and then after that we want to earmark the health tax, maybe 10% or 50% for the universal health coverage. And I think it is done. It is already done by the Philippines, and also for with the variation in the detail by the Thailand also. There is earmarking for public health, maybe not all for the universal health care, but also for the health promotion. And I think Indonesia can follow them, and maybe this idea is also relevant for many other developing countries with the same health challenges like Indonesia. So, and I think the ministerial collaboration, ministerial meeting under the G20 can play a role, to propose or to advocate on this idea. Back to you.
Thank you, Pak Abdillah. Just one follow-up question. Do you think that the civil society or non-governmental organizations will have a role on this policy proposal, Pak?
Oh yes, because civil society and other interest group play important role in the democracy, in the Indonesian democracy, and I think many G20 countries all the democracy. So the pillar of democracy is civil society, and it is very important to have civil society voicing this idea, to make sure that universal healthcare and also the health promotion can be sustainable, so that the human resources quality can be improved in Indonesia. So I think it is better to solve the problem in the beginning, not in the end. In the beginning and in the end. So like health promotion is in the beginning, and the UHC is in the end. So we have to make sure that both of it has enough and sustainable funding.
Okay, thank you so much, Pak Abdillah. So as we are almost run out of time, maybe I can share a bit of the summary of our discussions. The presentation from Pak Abdillah, he's stressing the problem to the underfunded of universal health coverage and the emerging burden of disease. Moreover, he also highlighted the fragmented funding, inequitable primary care services, and the global health disparity. And so he suggested to apply the health tax and earmarking on it. This recommendation specifically aims to those products that have a negative public health impact, including, but maybe not limited to, tobacco, alcohol, and SSP, also SFC. So the point of this recommendation is not only targeting the financial aspect, but also for health risk reductions. And the second presenter from Dr. Monica, she underlined that the international community is currently struggling to finance global issues such as what we're just facing in the last 3 years, and even still, the COVID-19 pandemic, for instance. And she recommended to shift the paradigm of the international public finance by using the modality of the global public investment, or GPI. So all countries can share amount of contributions, and it can be dispensed through global finance mechanisms, mainly to 5 areas, including health, digital transformations, and development bank, climate and disaster risk reductions. And I also find cross-cutting concerns that perhaps civil society, non-government organizations, and other private sectors may have a significant role on these recommendations. And I think that's the key of public-private partnership, as discussed in the previous sessions. So as we are coming to the end of these discussions, thanks again to Pak Abdillah and Dr. Monica, our great presenters, and also all audience for staying awake, especially to those who raised some brilliant questions. So yeah, I'm Eri, as the moderator of these sessions. I hereby close the discussion and hand this over to the MC. Thank you, everyone. Thank you, Pak Abdillah, Dr. Monica.
Thank you so much,
Thank you so much
for moderating the discussion, and also thanks to the two of our presenters. What a way to close the webinar, and hopefully we can all get the insights from the two sessions that has been concluded on today's event. So, ladies and gentlemen, let's just continue the event with the summary. And to deliver the summary of today's event, please welcome the Chairman of Indonesian Health Economist Association, or InaHEA. Please welcome Mr. Hasbullah Tabrani.
Thank you, Mas Rizky. Good evening, everyone. Thank you, Monica, Patila, Freddy, and all those who are already contributing, working hard for this. I've been enjoying the discussions in yesterday. A lot of ideas, a lot of evidence, fact were presented, and just also presented tonight, this afternoon, morning. We now having a lot of ideas, issue, evidence that will be submitted to the G20 meeting. The T20 summit will be organized early September. Before that, I see several other organizations also doing a lot of webinar discussion, roundtable meeting, and so on. Try to get ideas how to improve the global health, the people centers, keeping everyone in this planet healthy and productive. I think that has been a great initiative after the COVID-19 affect all the world. Yes, it is blessing in disguise. I would say the pandemic has strongly impacted all people around the world, all countries, reducing the global GDP by almost 3% in 2 years ago, and maybe now it's already recovered, and maybe still some increase. But on the other hand, we have a lot of ideas how to recover from this pandemic. So the government of Indonesia already put the slogan, recovers together, recover stronger. So these 2 days meetings already show us how we share together our experience, to be able to have a better world. I will just mentioning some of the key points, key takeaways that we learn, we got from this, especially from today, this second day meeting, that the countries all over the world has different level of capacity in responding to pandemic. Richer countries certainly are having better modality, better capacity prepare for this kind of pandemics, but low and middle income countries still not good enough to handle that. Even for primary health care, which is normally not very expensive to invest and to strengthen, although the discussion on strengthening primary care has been on the table since the Alma-Ata 40 years ago, almost 50 years ago, sorry. But in reality, strengthening primary health care still still having a big challenge. First, because when we're talking about primary health care, we don't have the same understanding, same definition of primary health care. Yes, there a lot of jargon saying that putting primary health care will save money, will be much more effective. But in reality, there are challenges for that. Some evidence demonstrated tonight, in the second day, in several ASEAN countries, in India, and also some countries outside the Asia, that proven effectiveness, helpful public-private partnerships, supporting by also CSR money, but still there are challenges for public-private partnership. Data showing improving, for example, from India, improving performance, but there are challenges, as mentioned by our colleagues from the Philippines, that private sector would like to see how they can improve with large volume, with incentive, disincentive. Certainly the private sector working with that. And also the regulatory environments needed. Yes, we do have a perspective to improve private sectors. Public sector must also be strengthening. Funding for the public sector in some countries already good enough, but across countries not good enough. So when we do have effectiveness and improving access by working together, public and private sectors, funding remain big issues. Yeah. There are initiatives of improving funding by mobilizing syntaxes. Syntaxes can be mobilized from the traditionally cigarette, as presented, discussed today, but more and more countries are interested to control more than cigarette, which also contribute to a higher risk of non-communicable disease and can strengthen financing for public sector, especially in the primary care level. Certainly, earmarking cannot be done by private sector because the nature of its earmarking must involve regulatory and collected by states, not by private sector. But the private sector can contribute to that by matching some funding, providing medical equipment, diagnostic, the regimens that can improve and also certainly that can improve the performance. There are, however, problem of inequity of funding, the global public investment or global financing for public good, whatever the names are also discussed today. I certainly agree that current financial intermediary funds that been agreed on the consensus last month in Jakarta on the joint ministerial meeting of finance minister and health ministers. However, that's based on the first stage of the global funding or global public investment, whatever the name, that can be used more effectively, more equitably across different countries. Certainly, the best way the best way is to mandate every country to contribute. This is the ideas of social health insurance, as Monica described, and this Germany's introduced first social health insurance model, mandatory, and everybody has the certain right for that. The challenge for this, how to convince the G20 leadership, is still big. Whatever the combination of funding, strengthening healthcare providers, primary healthcare, strong political leadership and political consensus remains a big challenge for us. We have to find some way how to convince them. Yeah, I think that's probably the free summary that I can share with you. Written summary in more detail of what we learned from today's presentation will be shared to you. Please, our colleague, share what we have written there to all participants, since all participants already filled the presences and email or some other address. Please share to them that they could also follow up with the influencing countries or representative of their countries or their delegates to increase the chance that what we have discussed tonight and yesterday can be incorporated in the G20 summit meeting in November in Bali. Thank you for all. I return back to Rama. Thank you. Have a great day, great night, and good sleep. Thank you.
Thank you so much, Mr. Hasbullah, for delivering the summary. Ladies and gentlemen, that's all of the 2 days webinar. We would like to thank all of the speakers, moderators, and participants for joining us today. Before we close the event, ladies and gentlemen, we would like to invite all participants to attend our future events. May we see the schedules? Okay, our nearest events, ladies and gentlemen, is a 2 days webinar, which will be held on August 2nd until August 3rd. The webinar aims to introduce the Airborne Infection Defense Platform, or AIDP, to all G20 stakeholders, Task Force 6 stakeholders, and tuberculosis stakeholders about the AIDP. The EIDP itself is intended to extend national tuberculosis program and deploy new technologies, including community use of ultra-portable radiography and digital innovations to quickly and accurately detect tuberculosis while accelerating the detection of other airborne diseases. And once again, the event will be held on August 2nd and August 3rd, so please make sure to register yourself as soon as possible. And also our other event will be held on the next day, which is the August 4th. And the title is Optimizing Access to Diagnostics, Therapeutics, and Vaccines During the COVID-19 Pandemic, Reflections on Lessons Learned. Just like most of our events, these two events will be held online. So make sure to book your reservation throughout the link that is shown on the screen. And for more information about our our other events, please visit our website on the T20Indonesia.org. And we also would like to remind everyone that our event is being live streamed on the official YouTube channel of the Faculty of Public Health, Universitas Indonesia. And later on, we are going to upload the whole webinar on the T20 Indonesia official YouTube channel. So all of us can rewatch the webinar and regain new insights from the 2 days event. Ladies and gentlemen, once again, we would like to ask our participants to fill out the attendance form as well as the evaluation form that has been sent in the chat box feature. So please fill out the evaluation form so that we can conduct our next event better. And the link is shown on the screen. And also, if you would like to download the materials that has been presented today, you can also download the materials by accessing the link that is shown on the screen. Yes. That's all of the information that I got today. Thank you so much, ladies and gentlemen, for coming to the 2 days event. My name is Rizky Ramadan. Once again, thank you for coming to the T20 webinar, Putting People at the Center of the Health System. And we hope to see you on our next events. Thank you. Terima kasih. Have a good day, everyone.
Thank you. Terima
Great,
kasih.
thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you.